Good afternoon. I'm Paul Mirabella, Chairman and CEO of Naviscan. We're here today to discuss the use of a new tool in the fight against breast cancer. This technology is known as PEM, or positron emission mammography. It is an organ-specific PET scanner optimized for breast imaging. It's the highest resolution tomographic molecular breast imaging technology available, and it's used to accurately find and correctly diagnose and characterize the extent of disease, to gauge the response to neoadjuvant chemotherapy, and to monitor for recurrence. It is a patient and user-friendly compact system utilizing gentle immobilization and positron emission mammography to show an exquisite high-resolution 3D anatomical image and the metabolic activity in the breast. PEM scanners are not screening devices, but rather are used to identify small satellite lesions to define the extent of disease and allow radiologists to provide surgeons and oncologists with critical and essential information needed to guide therapy. Tomographic slices of the anatomy, combined with the ability to gauge the response to an isotope that is metabolized by cancer, is critical to making the right surgical decisions, reducing unnecessary procedures, which increase patient trauma, and reducing costs to the healthcare system. The power of tomographic molecular breast imaging, whether displayed in a slice representation or displayed as a true 3D animation for referring physicians, is self-evident. I'm pleased this afternoon to introduce several speakers. First, Dr. Wendie Berg will share the results of a landmark NIH-sponsored clinical trial, a multi-site prospective randomized study focused on quantifying the performance characteristics of PEM versus breast MR, defining the advantages of PEM, and the impact on the surgical management of patients. The paper presented earlier today in the Erie Crown Theater is the first of several manuscripts associated with this study and was recently released in the online edition of Radiology, a one-page summary of which is included in your press kits. Dr. Berg, one of the foremost leading authorities and published academics on the subject of breast imaging, is currently the study chair for the American College of Radiology Imaging Network, or ACRIN, the ultrasound breast imaging section. She was one of 6 site investigators in the NIH trial. She's the lead author for this manuscript and was the principal investigator for the study. She will present a summary of her findings and offer her perspective on the advantages of PEM and its appropriateness in the clinical care path. Following Dr. Berg's presentation, Dr. Mark Gittleman, former president of the American Society of Breast Surgeons, who practices in Allentown, Pennsylvania, at a comprehensive breast care center and has been using PEM for the last 3 years, will offer his perspective on how PEM has affected his surgical practice and the day-to-day management and treatment of breast cancer patients. Finally, we're pleased to present 2 patient testimonials which will give you a unique perspective and a very personal perspective on the impact of this technology. I'll then conclude with some final remarks regarding the availability of PEM throughout the United States and beyond, as well as some of the national healthcare delivery organizations that have begun to make PEM available to patients throughout their network. So without any further ado, Dr. Berg.
Thank you, Paul. It's a pleasure to be here this afternoon. PEM is, as Mr. Mirabella said, a high-resolution tomographic technique that allows us to image positron-emitting tracers. Specifically, we use sugar, in this case, the radioactive glucose, which is taken up by cells that are growing and rapidly dividing, and especially taken up by cancers. The positioning, as you can see in this image, is very similar to mammography, and we use very gentle compression. It's just to stabilize the breast. This is not at all uncomfortable to patients. In fact, it's very well tolerated. We do the same views as we do for mammography, and if we need to do additional views to image the very posterior tissue or axillary tail region, we can, just as we do for mammography. The result of this is an image like this, where we have 12 slices of the breast. And this gives us exquisite detail. In this case, the patient had a known cancer in the region right behind the nipple, and you can see uptake of the sugar in multiple additional lesions in this breast, and she had multicentric as well as multifocal disease, and needed a mastectomy, and this was much better depicted on the PEM images than on the mammogram to your left. What we studied was 388 women who were enrolled at 6 centers in this country, all of whom had newly diagnosed breast cancer and all of whom were considered candidates for lumpectomy surgery. As Paul mentioned, this study was funded by the NIH as well as Naviscan. Importantly, these patients all underwent both PEM and MRI examinations, MRI currently being the relative standard of care in looking at extent of disease, and these exams were independently interpreted. What we found was that essentially a fifth of these women, 21%, had additional cancers that were not known at study entry. Of those additional cancers, 34% were seen on both PEM and MRI, 26% only on MRI, and 17% only on PEM. So the two tests, PEM and MRI, are complementary. Neither is perfect in isolation. Importantly, as we had hoped to find, PEM was less likely to prompt an unnecessary biopsy. If a lesion was seen on MRI, 41% of those turned out to be cancer, but significantly higher, 55% were cancer if the lesion was suspicious on PEM. And as I mentioned, the exam is well tolerated and there's no issue with claustrophobia. About 15% of women in general are unable to tolerate an MRI examination. And here's just an example of a patient who was 37, who had a palpable lump marked by a BB. There were calcifications on the mammogram. You could see this mass on ultrasound as well. This was a high-grade invasive and intraductal carcinoma. The MRI, in her case, showed the cancer, but also showed multiple additional indeterminate findings that were considered suspicious. She underwent additional biopsies that were benign from both breasts, and the PEM, in her case, correctly showed the known cancer and 2 small satellite areas of DCIS that was perfectly matched with the pathology in her case with no false positives. So the MRI caused extra biopsies for her. And here's just a comparison to the whole body PET imaging, and you can see much better detail. In this case, she had a PET CT. Here's the PEM with the additional foci. You do not appreciate that level of detail with PET CT. And PEM was significantly better at showing disease extent than either PET CT or whole body PET in a sub-study of the patients we examined. In conclusion, PEM is highly effective in assessing the extent of disease in women with newly diagnosed cancer. It is an acceptable, now proven prospectively in a multi-center trial, an acceptable alternative to MRI. It complements the MRI examination, and it is less likely than MRI to cause unnecessary biopsies. And I want to thank you to the sites. I know some of our investigators are here in the audience, and I appreciate your help with this study. Thank you for your attention.
Thanks, Dr. Berg. And now I'd like to invite Dr. Gittleman up to offer his perspective on his experience over the last 3 years.
Well, I want to first of all thank Mr. Mirabella and the Naviscan family and Dr. Berg for inviting me to share the podium here this afternoon and share my perspective on the clinical importance of PEM imaging. I'm a breast surgeon, and so I rely on the results of various imaging tests to help me in taking care of my patients for treatment decisions, what type of surgery, the extent of surgery, and so on. So it's critically important for me as a user to obtain helpful, valid information. The study that Dr. Berg just went over with you is very important to me and reinforces my impression, my clinical impression over the last few years of the validity of using PEM in my clinical care of patients. I've been a user of PEM for the past 3 years and have been very pleased with the results. I have the good fortune of being able to compare a number of the imaging modalities in my clinical practice, including PEM and MRI. And as this study showed, I found also, I've had the clinical impression, again validated by the study, that the PEM study really gives a better or a higher specificity, meaning we have less false positives and therefore will lead us to do less biopsies as compared to MRI, which has a relatively lower specificity than does the PEM scanning device. So I just want to share with you my perspective on this and show you a few case examples. Some of the problems that we avoid with PEM, such as a clip artifact. A clip is a small piece of metal that's placed into the breast following a biopsy, so it'll be visible for future imaging studies and follow-up care of patients. The problem with MRI, when an MRI is done in a patient who has a clip placed in the breast, we can get a flare artifact, which makes it somewhat difficult to identify the area clearly. We don't have any such artifact generated with the PEM evaluation. Also, we found examples of PEM, I found personal examples of PEM, that additional cancer is seen with PEM, but not the mammogram or the MRI. In other words, a greater sensitivity in the PEM as opposed to MRI, which does change the treatment planning, which is pretty obvious. Also, the very important thing that we just went over, and that is the specificity. If I have an MRI that shows a lesion in the breast or a second lesion in the breast of some concern, but the PEM does not identify that, as Dr. Berg just showed in her example, I rely more heavily on the PEM and take much more clinical information from the non-appearance of that MRI-detected lesion than just basing treatment recommendations or further surgical procedures based on the MRI alone. And also, I find in my practice that MRI is not possible in some patients where we'd like to have additional advanced imaging beyond the mammogram and the ultrasound. And as you may be aware, patients who have pacemakers cannot have an MRI due to the magnetic field generated by the MRI. Some patients are just too claustrophobic. Dr. Berg said about 15% in her study, and I would estimate in our practice it's easily 15 to 20% of patients who just won't tolerate having the breast MRI, or they've had it one time and they're never going to go have one again. Sometimes the patient's size, a physical limitation, prevents us from doing an MRI on a patient. Reactions to gadolinium and also patients in renal failure are not good candidates to have MRI. So about 20% of patients we want to have advanced imaging really can't have the MRI for those reasons. This is an example of the clip marking the biopsy site. In a patient who had a previous biopsy, a marker is placed where there's a known cancer. One would think that when we go to the operating room, we're going to target this area and remove this area based on where the marker is. But we found on the PEM evaluation, the cancer actually is more posterior in the breast than this clip would let us think. And therefore, for our surgical planning, we're encompassing this area back here, not just the area where the marker is. So a very important principle that the clip can be not necessarily where the cancer is when we may be directing our surgical attention to the clip. Also, we can find unsuspected second lesions. Here's a patient with a mammogram with a known cancer here. When the PEM was obtained, we found the cancer, but we also found a second site unrecognized on the mammogram, and therefore this led appropriately to a mastectomy as opposed to breast conservation surgery. Also, PEM can pick up cancer in the opposite breast. Here's a mammogram showing an obvious cancer here. It was diagnosed in the right breast. Well, the PEM will show that, but it also showed the second lesion or an additional lesion in the opposite breast, leading us to perform appropriate surgical procedure. This is an example of a case that had both an MRI false positive and false negative in one patient. In this patient here, we had an MRI detected lesion which was biopsied and found to be not a cancer. Therefore, there was a false positive with the MRI. When we got the PEM result, though, we found the cancer not only in this breast, but we found a cancer in the opposite breast not picked up on the MRI. So here in one patient is an example of the MRI being both false positive and falsely negative. Here's a patient of mine, 73 years of age, who had a PEM examination done. As you can see in the lower images here, we knew about this cancer. We didn't know about this one. So from a surgeon's perspective, rather than just taking out this area, I'm going to encompass a wider area which will allow us to have clean margins and a much reduced risk of a local recurrence. Here's my last patient, a 42-year-old patient, who had a left breast cancer seen on her mammogram. That was this shown also on the PEM. What was not on the mammogram, though, was this cancer in the right side. This was biopsied based on the PEM after a second look ultrasound was done and also found to be an invasive breast cancer. So now this 42-year-old has both right and left breast cancers unsuspected just on the mammogram itself. And the importance of this is, due to the bilateral breast cancer found in this individual, 42 years of age, he was tested for the BRCA or BRCA gene mutation. She was found to be positive. So that not only she underwent bilateral breast cancer treatment appropriately, but also had bilateral ovary removal, which prevented the development of ovarian cancer. So a very important example of the BRCA testing being dictated by the bilateral breast cancer noted by PEM imaging. So that's been my experience with PEM. I found it extremely helpful and will continue to use it based on this study and I'm sure future publications. Thank you.
Thank you, Mark. Now here's a more personal perspective from two patients whose lives were changed by access to this technology. The first patient could only get a correct diagnosis because of PEM, and the second patient could only tolerate a PEM exam. Both stories are quite compelling.
Last May, and May the 30th actually, was my daughter's 3rd birthday, and we had planned a huge party at a water park. As I was dressing, I noticed on the right side of my dress a blood stain. And I don't even know what I was thinking. Certainly not breast cancer, but I knew something was wrong. I just thought that, having had the ultrasound and the mammo and then having the MRI, that this was going to be the deciding factor. And it wasn't. It was just kind of like, well, the MRI can only see so much. And so it was kind of disappointing. Once I had the PEM scan, there was no question in Dr. Coletta's mind that I would have to do a mastectomy. Lumpectomy was off the table at that point. For me, the PEM, basically for the first time gave me the answers that I had been looking for. And so that made the difference for me. I'm just very grateful that, this was caught early. I have 2 small children, and I'm here today, I'm alive today to be able to spend time with them. And so to me, that makes up for everything. So I'm a very, very grateful survivor.
They explained to me that I had a very suspicious looking lesion that they suspected was probably cancer. They scheduled me in a few days for a stereotactic biopsy. During that procedure, they must have hit a vein and I had a bleed, and they tried to continue but they couldn't, so they suggested that possibly they should try a sonogram needle biopsy. They weren't able to because the hematoma was masking the area that was suspicious. They scheduled a breast MRI for me, and I thought I might have a problem because I am a little claustrophobic. But I thought, well, I'm certainly going to give it a try. And they said, oh, you'll be fine. We can give you a little sedative beforehand if you like. As soon as I got in that MRI with, face down, and the machine started coming around me and started touching my body, I just panicked. Following that, they did the PEM scan, and my right breast just lit up with the area of cancer. The PEM biopsy, which happened a few days later, they were able to remove the cancer cells, have them tested, find out that I had kind of a rare kind of breast cancer called triple negative, and it's very aggressive apparently. So I was so glad to find out that I had cancer and that I was still in a period of time where I could be treated, because I might have gone home and it could have, 6 months could have gone by and who knows what would have happened. I would definitely recommend a PEM scan for anyone who's going through any type of, where they have a suspicious area that needs to be examined further. In my case, there was nothing else that would have worked because it was deep inside my breast, back against the chest wall, and I don't think there's any other method that would really have taken care of that and found it so that I was able to treat it and, be here today.
At the risk of oversimplification, I can try to summarize the impact of PEM technology with this one case. A simplistic definition of specificity is the ability to correctly differentiate malignant from benign lesions. This slide represents the breast MR exam of a 44-year-old woman with bilateral breast implants. MR found what was believed to be bilateral masses that would have resulted in bilateral biopsies. In fact, PEM confirmed that the mass in the right breast, shown here on your left as cancer. However, PEM also showed that the apparent pathology in the left breast, suspected as a result of the breast MR exam, was in fact a benign fibrocystic change. The diffusion of PEM technology is accelerating. It's now available at over 45 centers around the world, And in response to the growing acceptance and demand by academicians and community physicians alike, we're announcing today the addition of several strategic relationships and a substantial increase in our commercial coverage, which will allow us to respond to that demand. First, well-established leadership organizations such as US Oncology and Alliance Imaging are now providing these services to radiologists, surgeons, and surgical and medical oncologists, and most importantly, to patients. Secondly, we've already doubled the size of our sales force in the United States and expect to quadruple it by the middle of 2011. And finally, we have significantly expanded our international coverage through the organizations listed, with the exception of the fact that we're still in negotiations getting preparation for our European launch at the European Congress of Radiology in February. The bottom line is that this game-changing technology has allowed us to double our sales revenue and this year, and we expect to double it again next year. I thank you for attending and for your attention, and we'll be happy to answer whatever questions in the time remaining. Assuming I could actually see anybody raising their hand with the lights in my eyes. Are there questions? If not,
at the risk of asking a question I should know the answer to, just in the course of the study here, you mentioned 4 different technologies used to sort of graft breast cancer in its various stages. Do you see this, and you sort of presented it as an additive technology rather than a replacement technology for the other alternatives? Do you think at some point it becomes replacement rather than additive? What value do the others bring?
well, I think we actually tried to present it, and then I'll let both Drs. Berg and Gittleman comment. What we tried to present, first and foremost, is this is an alternative, and arguably a better alternative because of the specificity improvement, than to breast MR. So it's not presented as an alternative for screening. It's presented as an alternative to find the extent of disease, at least at that stage in breast cancer care. As far as it being a replacement, I don't necessarily think it's ready to be a replacement to anything at this juncture. It certainly, as the results in Dr. Berg's study showed, of our multi-site NIH study, it certainly is a complementary technology because it improves the overall sensitivity of the combined modalities, so you find more cancers, and together with its additional specificity is likely to be able to show which ones are or are not really cancer.
It's a very good question that you ask. I'm not sure that it's certainly not ready to replace MRI at this time. I do think that in patients who can't tolerate an MRI, it's certainly a reasonable alternative. I don't think we would advocate doing both, although there was this complementarity. I think that would not generally be necessary, although there are patients who have a very busy MRI where we really pull our hair out and aren't sure at all what's going on. And in that situation, I think it can be very helpful. We certainly did find that helpful at our own center, where we actually accrued a large number of patients to the trial. And we were very glad to have that extra piece of information in some of the very busy MRI cases to really direct our attention to the areas that were more likely to be cancer.
You're using the word busy to describe the complexity of the image,
Busy
not
breasts,
the fact that
yes.
it's not the MR is busy.
The active breasts with lots of lesions that enhance.
From my perspective, I certainly agree with what's been said. And in addition, it's just like an ultrasound doesn't replace mammogram, and they're complementary studies and they're additive. Same thing with MRI and PEM. I don't see PEM replacing MRI, as been mentioned, at least not at this point, but I do see the indications for PEM broadening in the future as we gain more experience with it. I do believe, as with MRI, we're going to see PEM indicated as time goes on for evaluation of the patient who is at high risk of developing breast cancer, not just for the patient who's already been diagnosed with a breast cancer. So I think that's something I see in the future, just like MRI started out not necessarily for the high-risk patient, but rather for the patient who's been diagnosed with breast cancer. I see the same thing happening with this now. So the indications will broaden, I believe, in the future, and hopefully it'll be appropriately so. And
one of those broadening applications is its use more broadly in looking at neoadjuvant chemotherapy response. Frankly, because of the study and the paper published to date, which is the ipsilateral paper, we really have focused on extent of disease. But if there's a magic picture here, it's in being able to see that after one round of chemotherapy, you can not only see the shrinkage of the tumor, but you can see the change in metabolic activity, and that's very powerful. From the patient's standpoint, they don't want to get chemotherapy that's not working, and from the payer's standpoint, you know, they don't want to be paying for a drug that's not working. So I think it's very powerful for the clinician, for the patient, and the payer. And I think they're probably going to throw us off the stage. If you have more questions, we'll be happy to answer them one-on-one. Thank you.
Thank you.